brolucizumab injection. 22 days after receiving topical and oral steroids, we noticed resolving vasculitis but with still persistent disc edema. FFA showing disc hyperfluorescence 6 weeks after. This is the disc edema even persistent after 70 days. So the diagnosis of brolucizumab-induced peripheral vasculitis with disc edema was made. Rest all other investigations for the uveitis came out to be within normal limit. So now comes to the discussion. Brolucizumab is the latest FDA-approved anti-VEGF agent that was shown to be non-inferior to aflibercept in visual acuity outcomes in the pivotal Hawk and Harrier trials. In phase 3 clinical trials of brolucizumab for NAMD, ocular inflammation was reported to be higher in the brolucizumab group as compared to the other aflibercepts and the ranibizumab group. So what is basically the mechanism of action of brolucizumab? It is a humanized single-chain antibody fragment that inhibits almost all the forms of VEGF-A. Basically, its small molecular weight, high molar doses, and its high drug concentration allow its remarkable effect, which is almost 11 times of the dose of aflibercept and 22 times the dose of the ranibizumab. Its mechanism of action of vasculitis, basically how it causes vasculitis, is due to the presence of pre-treatment anti-drug antibody found to be 35 to 52% in the treatment-naive patients. This is contrast very high as compared to the other groups. It is basically type 3 deposits which play a significant role of AD in these reactions. It can also be hypothesized that with the combination of its high dose and the diseases such as the diabetes, which is basically the weak blood-retinal barrier, allow its effect more and causes the chances of vasculitis more in the diabetic patient as compared to the patients who have non-diabetic and only has neovascular age-related macular degeneration. This is from one of the articles showing intra-article gray deposits resolved on its own. This is another one which resolved on the topical steroids. So now the question arises whether there are increased chance of vasculitis after multiple injection. Basically, retinal arterial occlusion with severe vision loss, possibly secondary to the inflammatory responses, can occur after subsequent intravitreal brolucizumab injection, even if no inflammation occurred after the initial first dose. This is another article. This patient, in the top row patient, received the intravitreal bevacizumab. No reaction occurred, but same patient received intravitreal brolucizumab in his left eye, and we can see the intra-arterial grayish deposit 21 days after the injection. So now the question arises how we can diagnose this disease. With a complete thorough fundoscopy examination, wide field FFA, so we can detect the hyperfluorescence, staining of the vessel walls. Basically, clinicians are encouraged to use wide field imaging only with peripheral sweeps for a quantitative examination of the entire retina to detect any inflammation, leakage or ischemia. Treatment, it is important to detect early type 4 hypersensitivity reactions because these can occur even up to after 6 weeks. FFA changes can be seen even after 8 weeks of the injection. Basically, this condition resolves with the help of topical and the oral steroids, but in few cases, it can be required intravitreal corticosteroids, triamcinolone acetate, and other corticosteroid implants. So, whether to repeat brolucizumab, right now, Novartis recommends withholding additional brolucizumab if intraocular inflammation has occurred after use. So, the conclusion that a case of retinal artery peripheral vasculitis after multiple injections of the brolucizumab for IPCV. Fortunately, early diagnosis and treatment after disease onset prevented its severe visual impairment. Thank you.
Very nice presentation, Dr. Priksha.
Thank you.
So, what was the final outcome of your patient? Like after 70 days itself, still the vasculitis did not resolve completely?
No, sir. Vasculitis resolved. Only there was a persistent disc edema, but it also resolved eventually, only with the help of topical as well as oral steroids.
Achha, so you needed both the things to resolve. And during this time, what was the state of the visual acuity of the patient?
So there was not much visual acuity affected because she was already in case of IPC. Her vision was never 6/6. Vision remains almost stable. But she came to us with the complaint of fluctus. She has received many injections in the past, but she never complained. But this time, with a different molecule, even she received past 2 brolucizumab also, there was no complaint. But this time she came to us with the complaint of fluctus. She said, this time I am not feeling exactly before because she has received many injections. So this time she was a bit uncomfortable. So then we did the investigations and in the very periphery only vasculitis was there.
So if there is a peripheral vasculitis, incidental finding,
yes, sir.
No vision decrease, will you treat?
Yes, sir.
Okay. So in all cases you are doing optos? What is the recommendation after intravitreal? What do you do?
No,
How
sir.
do you follow?
Usually we are not doing in every patient of octo, but in this case we already know that the brolucizumab there is already a chances of high chances, so we were already worried. And she complained of floaters, so we did the fundoscopic examination and then we did the octos.
Which cases you have given this drug? These cases were resistance to IVR?
Yes, sir. These were she was not improving markedly as compared. So we tried another molecule, shifting.
Shifting of the
Yes, sir.
Okay. Anyone would like to? Thank you.
Thank you, Priksha.
Thank you.